Hey guys, Miss Mary here. Tonight we've got a complicated one, but I'm going to try to make it as easy as possible. Hematopoetic agents and drugs for anemia. So we're going to go over the drugs and the different medications as well as the different types of anemia. So let's go. Okay. So our objectives are going to be, we're going to be able to explain the process of red blood cell development and the metabolic functions and fate of iron in the body. Identify the daily requirements for iron across the lifespan, define anemia, and state the different types that are included in this presentation. Describe the causes, consequences, diagnosis, and treatment of iron deficiency anemia, B12 deficiency, and folate deficiency. Those are nutritional deficiency anemias. And then compare different iron formulations, B12 and folate recommendations for administration. We're going to identify the drug interactions and toxicity that can occur with iron therapy, the guidelines for treating iron deficiency anemia, B12 deficiency, and folate. We're going to explain hematopoiesis and the physiology of it. We're going to identify the indications, major events and adverse effects and drug interactions with erythropoietic, leukopoietic, and thrombopoietic growth factors. In other words, medications that we can give to stimulate the production of red blood cells, white blood cells, and thrombocytes or platelets. So here are the different types of anemia. So let's get started, okay? And I want to actually get my face out of here so we can see the screen. So iron deficiency anemia or microcytic anemia. So iron deficiency anemia, you need iron in order for your body to make red blood cells. If you don't have enough, then you're not going to produce enough red blood cells. There's vitamin B12 deficiency, megaloblastic or macrocytic anemia, also called pernicious anemia. B12 deficiency anemia, you need your B vitamins, especially B12, to make red blood cells. And when there's a B12 deficiency, pernicious anemia, that one has some weird symptoms, and we're going to talk about that, neurological symptoms. And chronic anemia occurs with a shortened lifespan of red blood cells because of either inflammation, size, color, different things. So if you look at the chart here, you can see we've got normal red blood cell, right? Kind of an oval shape with a concave center. Macrocytic, it's too big. Microcytic, it is too small. And then there's an oval macrocyte, wrong shape and too big. And then the color, okay? Hypochromasia, which is not enough of the red. Polychromasia, right, which is too much. And hyperchromasia, which is even more, right? Then there's a variation that can happen in the shape of the red blood cells. Remember, they're supposed to be oval, right? Like we said at the beginning. And so if they're anything other than that, it's a problem. Think about, let's go right to sickle cell anemia. The red blood cells become shaped like a sickle, okay? When they're shaped that way, they can't fit through blood vessels and they start to aggregate at the beginnings of different blood vessels all through the body, which is what causes the horrible pain with sickle cell anemia. You can have them shaped like teardrops. You can have them shaped like a very long elliptical shape, fragmented, which is they're kind of in pieces, different kinds of misshapes of red blood cells that can occur. And then when it comes to red blood cells, you can have blastophilic, you can have a Cabot ring, and we're going to go over all of these as we move through. So let's move along. Okay, where do red blood cells get made? Where are they made? In the bone marrow. And then they mature in the bloodstream. The earliest stage is a pro-erythroblast. No hemoglobin there. Okay, so pro-erythroblast up here. There's no hemoglobin, and that's what's going on in the bone marrow. That then becomes an erythroblast. And in order for that to happen, again, B12, all the B vitamins, iron, protein you need. And you also need erythropoietin that's made in the kidneys. Okay. Once it's an erythroblast, then it gains the hemoglobin. In other words, heme, iron binds to it, becomes a reticulocyte. And that's just kind of a baby or immature red blood cell that goes into your systemic circulation, and then it becomes a full-grown erythrocyte. And that's just a mature, can do what it needs to do, red blood cell. Okay. So now, in order to make red blood cells, your bone marrow's got to be intact. Your kidneys have to be functioning to make that erythropoietin. You have to have iron for hemoglobin synthesis. B12 and folic acid have to be available to support the synthesis of DNA. And if any of these things are missing, you're going to have anemia. Inflammation can shorten the lifespan and lead to anemia for different reasons, right? So what happens to iron in your blood? So iron is essential to the function of the hemoglobin, okay? So iron, the heme part, binds to the red blood cell. Myoglobin, which is the oxygen storing molecule in the muscle, needs that. Your iron gets absorbed in your small intestine, about 3 to 4 milligrams a day, and you get that from diet, right? 5 to 20% of dietary iron is absorbed, and you need vitamin C to enhance the absorption of it, okay? There are different foods that can reduce the absorption. And when you take in dietary iron, it's stored as ferritin or transported as transferrin. And iron gets recycled in your body. So, in other words, a red blood cell's lifespan is about 120 days. So, at the end of that 120 days, it goes to the liver. The red blood cell, the hemoglobin, goes to the liver to die. The liver takes the heme, the iron, out of it, okay, and can store it and recycle it and store it. And you can make about 1 gram of iron every day. And your body regulate the amount of iron that you need based on your activity levels and all those things. Different situations can occur that can cause deficiencies in iron, like hemorrhage, if you're bleeding, menorrhagia, if you have very, very, very heavy periods, and even sometimes, frequent blood donations can all cause iron deficiency, not just a low red blood cell count. So this chart just explains how the iron gets broken down and recycled. Okay, it's amazing what the liver does. So what are the daily requirements of iron? Remember, only 10% of what you take in is really absorbed. For your average healthy adult, and when I say average healthy adult, because there are lots of different subcategories here, but an average healthy of childbearing age adult, somewhere between, if you look at the males from greater than 19, about 8 milligrams a day, and females 9 to 50, 8 to 18 milligrams a day, a little bit more because of periods, right? So anywhere between 8 and 18 milligrams a day of iron. Younger males need a little bit more, like 15, right? And so do children need a little bit more because they're growing and exponentially. So if you have an average diet, doesn't even have to be a great diet, but an average diet, you should be able to meet the needs of your body for iron. So what kinds of foods are high in iron? Remember, iron is found mostly in things like organs, right? Organ meat. So liver is loaded with iron. Egg yolks, brewer's yeast, wheat germ, muscle meat, fish, fowl, cereal grains because they're fortified, beans, and green leafy vegetables. Not so much milk. Okay. And people who have a really high iron requirement, like infants and pregnant women or people that are losing blood chronically, they're going to need supplementation because they won't be able to get what they need from diet alone. So let's start with iron deficiency anemia. Okay. This anemia causes a decrease in erythrocytes in the number, the size, and the hemoglobin content. So what are the causes of iron deficiency anemia? Could be pregnancy, right? Because you're eating for two. Could be blood loss. Maybe you have a GI bleed, maybe heavy periods. Phlebotomy, in other words, they're drawing blood. Hemolysis are the blood cells getting destroyed. Maybe there's something wrong with the bone marrow. Or maybe there's a deficiency of the substances that you need for red blood cell formation and maturation, or you're not able to absorb those nutrients, which are iron, B12, and folic acid. So maybe you're in kidney failure. Kidney failure, you're going to be anemic because your kidneys are failing and they're not going to make erythropoietin. So an imbalance in iron uptake and iron demand can cause iron deficiency anemia. Microcytic hypochromic anemia. In other words, they're too small and they're too pale, the red blood cells. There's only one reason for red blood cells to be too little and pale, and that is iron deficiency anemia. And it can be, again, pregnancy, infancy, chronic blood loss, that type of thing. What are the symptoms? Most of the symptoms of the different anemias are shared symptoms. In other words, they kind of look the same. So if you don't have enough red blood cells, you don't have enough hemoglobin, which means you can't carry enough oxygen. And that reduced oxygen carrying capacity makes you listless, fatigued, pale. You're going to have pallor of your skin and your mucous membranes, like your conjunctiva and your oral mucous membranes. Tachycardia. So if your body's not getting enough oxygen, your heart rate is going to increase. And your heart's going, where's the blood? Let me beat faster. Going to be short of breath, dyspnea. You can even have, if you're a child, developmental problems. And if you're an adult or an older person, cognitive problems. And anything that's less than a 6, you're going to need to go to the hospital for a blood transfusion. And iron deficiency can exist with a B12 deficiency. So it doesn't have to be just one reason for that anemia. So when we look at the hemogram that diagnoses anemia, basically we're looking at a CBC, a complete blood count. Okay. White blood cells, 3.8 to 10.8 in the ballpark. Red blood cells, 3.8 to 5.10 million. Hemoglobin, 11.7 to 15.5. Hematocrit, 35 to 45. MCV, well, you can read, right? So all of these numbers, again, you're in the ballpark, okay? Red blood cells, I usually say 4 to 6. White blood cells, I say 5 to 10. Hemoglobin, anywhere from 12 to 18. Crit, 35 to 45%. And then platelet count, 140, 145 to 500,000. Right. So what are these indices, the MCV and the MCH? MCV on that CBC means mean corpuscular volume. That means what is the average size of your red blood cells? RDW is the red cell distribution width. It measures the variation in red blood cell sizes reflected in the degree of the cytosis rather, on the peripheral blood smear. And then MCH is mean corpuscular hemoglobin. That's the average hemoglobin content in red blood cells, which gives them their color, the red, right? Iron deficiency anemia will produce small, pale red blood cells. They don't look right and they can't function right. So how do we diagnose anemia? If it's microcytic anemia, we look at the MCV and usually it's somewhere less than 80. And that's usually iron deficiency anemia. You'll see a serum iron level less than 60, IBC of less than 300, and ferritin for males and females a little bit different, less than 50 for a guy, less than 12 for a woman. What's the etiology? Again, could be diet, could be chronic blood loss, menorrhagia, in other words, your periods are heavy. You could have a slow bleed because of colon polyps or even hemorrhoids, which that would have to be pretty significant. Then we have megaloblastic anemia or macrocytic anemia. And that, again, that's a pernicious anemia. That's a B12 deficiency. And the MCV is going to be greater than 100. So these are big. Okay. Classification B12 deficiency. You're going to see a vitamin B12 level of less than 200. Okay. And we don't have an etiology in this PowerPoint, but I'm going to tell you that that can happen either because of diet, poor diet, or when people get older, there's something in your stomach and your gut called intrinsic and extrinsic factor that allows your body to absorb B12 orally from the foods that you eat. Older folks sometimes don't have enough intrinsic or extrinsic factor. Also, anyone who's had gastric surgery for weight loss may be deficient in intrinsic or extrinsic factors, which would then cause them to have a vitamin B12 deficiency, which then would require them to get shots of B12. And then folate deficiency, you're going to see a folate level that's going to be less than 2. That can be because of disease like celiac disease, intrinsic factor, enteritis, which is just inflammation of the gut, or you just don't get enough folate in your diet, so low dietary intake. Okay. This is a very blurry lab that we cannot see. So let's just talk about it. So what are iron preparations or, supplements that we give? Well, ferrous sulfate is the most common, and indications it's used to replace iron stores. It's usually dosed throughout the day in even doses. And 325 milligrams BID is probably the most that a body can absorb. What are the adverse effects? Because remember, everything has an adverse effect. GI disturbances, okay? And you wouldn't give it to them orally if the patient has like ulcerative colitis or enteritis or some kind of GI problem. It's going to make the stools black. So don't be alarmed. It's not a GI bleed. It's just a discoloration because of the ferrous sulfate. If it's a liquid ferrous sulfate, it will permanently stain the teeth. So you want to make sure that you instruct patients to use a straw, dropper, and rinse their mouth right after they take it. And again, you can become toxic even with something like an iron preparation. For children, a lethal dose is 2 to 10 grams. And if someone does overdose on iron, it's treated with deferoxamine. All right, that is your antidote. Drug interactions. Never ever take antacids with any oral medications, and of course, not with iron because it reduces the absorption. If you give it with any tetracycline, it's going to decrease the absorption of both the antibiotic and the iron. Vitamin C is a yes, yes, yes. It increases absorption, right? But it also can increase adverse effects. Food can decrease the absorption and decrease the adverse effect. Extended release formulas have variable and unpredictable absorption. So you're better off with just instant release. And usually we'll treat a patient for about 4 to 6 months to replenish the stores of ferritin that they have in their body. So the guidelines for treating iron deficiency anemia. First thing is determine the cause, right? So why are they losing blood? Reticulocytes should increase in 1 week once treatment begins, and hemoglobin should go up by about 2 grams per deciliter in the first month. If there's no improvement, you might want to, reevaluate and go with something different. You always want to make sure the patient understands adherence and side effects, and you want to continue treatment until their hemoglobin is normal, right? And the ferritin stores have been replaced. Now we can also give iron parenterally. So dextran can be given if the oral iron is either ineffective or they can't tolerate it. We like to give it IV, but it can be given IM, but it's got to be with a deep Z-track IM injection so it doesn't stain the skin. There are newer formulations, IV formulations of dextran that have less adverse effects. Adverse effects, as always, anaphylaxis, you can be allergic to anything, hypotension, headache, fever, urticaria, and arthralgia. So you can have, the hives or aches, joint aches. Now let's go to vitamin B12 deficiency. The consequence of not enough vitamin B12 is macrocytic anemia. And here's the kicker, injury to the nervous system. Any patient, especially older folks that present with neurological complaints, should be evaluated. Vitamin B12, which is cobalamin, is necessary and essential for the synthesis of DNA in the bone marrow. Absorption of B12, like I said earlier, requires intrinsic factor, and the daily requirement is 2.4 micrograms a day. 10 to 30% of adults over age 50 can't absorb it from their diet and need a supplement. Anything that suppresses stomach acid is going to decrease the absorption. Your best dietary sources are from animals, right? Which the same thing with iron. Best dietary sources are from animals or animal products. And then we're going to do diagnostic tests to find out if indeed this is the problem. So the causes of B12 deficiency are usually because of impaired absorption. Like I said, it's all about that intrinsic factor. It can be regional enteritis, celiac disease, lack of intrinsic factor. Pernicious anemia is actually what we used to call it. So it's vitamin B12 deficiency now. Same thing though. Metformin, right? Glucophage, the drug that we use, oral medication to treat type 2 diabetes, that can cause a B12 deficiency. Any drugs that suppress the acid, right, can also cause it. And what's the consequence of not enough B12? Megaloblastic anemia, big red blood cells. It can also be caused by drugs like phenytoin, which is an anti-seizure medication. It's not enough B12 can cause severe neurological damage, paresthesias, reduced deep tendon reflexes, memory loss, even psychosis, and any or all of those can be permanent. It can cause demyelination of the neurons of the spinal cord and brain. So, in other words, they may not be able to walk. They can also suffer from neutropenia and thrombocytopenia, not enough white blood cells or platelets. And one of the things, GI disturbances, ulcerations in the mouth, and a raised kind of reddened tongue, very, very inflamed tongue. Okay. Diagnosis. So, looking for B12 or folate, we do the Schilling's test to measure B12 absorption, which is an old school test. And then what do we do to treat it? Well, cyanocobalamin, which is a vitamin B12 preparation. We can give it oral, we can give it parenterally, IM or sub-Q, we can give it intranasally, but we don't ever give it IV. Intranasal is interesting. Just make sure if it's given intranasally, you massage the nair that you put it into after spraying it. Once you get the anemia corrected, then you give them about 100 mics a month, and that keeps them stable. Adverse effects, hypokalemia, and you may need to give folic acid because they may have a deficiency of that as well. Long-term treatment, if they don't have intrinsic factor, they're going to be getting probably sub-Q or intranasal injections of cyanocobalamin for the rest of their life. Give it with folic acid, and you can take that once a month. So folic acid requires activation in order for it to be used in the body, and vitamin B12 helps to catalyze the conversion of folic acid to its active form. And the active folic acid participates in several reactions that are essential for DNA synthesis. So, but the B12 influences cell division and growth by permitting the utilization of the folic acid. So they need each other. Folic acid needs B12 in order to convert to its active form to be useful to your body. Folic acid, also known as folate, is absorbed in the small intestine, transported and stored in the liver. Daily requirements, average adult, 400 mics a day, 600 a day if you're pregnant or breastfeeding, 2,000 mics a day for malabsorption syndromes. And where can you get folic acid? Again, liver, peas, lentils, oranges, whole wheat products, asparagus, beets, broccoli, and spinach, and grain products. Okay, lots of sources of dietary folate. Folic acid deficiency is really identical to B12, right? The initial treatment is 1 to 5 milligrams a day and then 400 mics a day, either PO or injected. Why do people get it? Alcoholics. Alcoholics, it's a big one. You will always see people that are in recovery with some kind of a folic acid supplement. Okay. They are usually alcoholics, have a poor diet, and there's derangement of enterohepatic circulation because of liver damage. Right. So they can't store it and they're not getting it from their diet. Also, malabsorption syndrome can cause it, and people that have had any weight loss surgery, like a gastric bypass. So, what are the consequences of not enough folate? Megaloblastic anemia, also leukopenia, thrombocytopenia, injury to the GI and oral mucosa, kind of like the B12 deficiency that you see. In a baby, in a developing fetus, if there's a folic acid deficiency in early pregnancy, that can cause severe deficits like neural tube defects, spina bifida, anencephaly. Okay. Anencephaly is without a brain. Okay. And if you're planning to become pregnant, you want to make sure you're getting 400 to 800 IUs a day of folic acid. And usually the primary care provider or the OBGYN discusses this with women of childbearing age. Fresh vegetables and fruit juice have a lot of folic acid, so they're good for you. Now, if you take big doses of folic acid, it can correct the hematologic consequences of a B12 deficiency. That's then masking the B12 deficiency. So it still exists, but you just don't see it. But folic acid will not prevent the neurological consequences of vitamin B12 deficiency that are irreversible. So if you're going to assess a folate level, always assess a B12 level and correct them accordingly. All right, hematopoetic and thrombopoetic growth factors. So the word hematopoiesis, it's the formation of white blood cells, red blood cells, and platelets. Growth factors are meds that act on the bone marrow to stimulate the formation of blood cells. Usually used, their therapeutic applications in patients with cancer, bone marrow transplant, HIV, and patients with chronic kidney disease. There are different types. There's hematopoietic and thrombopoietic. Hematopoetic growth factor stimulates RBCs and white blood cells. Thrombopoetic growth factor stimulates platelets. First one is epoetin alpha. Trade names, Epigen, Procrit, right? Aranesp. So this drug stimulates red blood cell growth in the bone marrow, and it's a great alternative to blood transfusions. Okay. It's given IV or sub-Q, and you do not agitate. In other words, never shake it. Okay. Why do we use it? Chronic renal failure. HIV infected patients taking zidovudine, you always are going to check their erythropoietin levels. Chemotherapy induced anemia, not leukemia or myeloid malignancies, but any chemotherapy induced anemia, and anemia in patients that are going to be having surgery, because we don't want them to go into surgery and be anemic. The adverse effects: hypertension, thrombotic events like a stroke or an MI, right? It's clotting. Risk increases if your hemoglobin level exceeds 11, or when the rate of the rise exceeds a gram per deciliter in any 2-week interval. So if the hemoglobin level goes too high, or the rate of the rise, even though it's not that high, it's only 1 gram per deciliter, but it's exceeding that in 2 weeks, period. And then autoimmune pure red cell aplasia. Severe anemia requires a blood transfusion. Neutralizing antibodies get formed, and it is basically an autoimmune disorder where red blood cells are destroyed. Okay. And that can be a side effect of the epoetin alpha. For cancer patients, the sad part is that sometimes epoetin can stimulate or accelerate tumor progression in patients with cancer and thereby shorten their life. And there's certain cancers that it's contraindicated for patients to get them. Their hemoglobin should never be higher than a 12, and the hemoglobin is always checked before treatment and then twice a week. Okay, before treatment and twice a week for cancer patients. Now we move on to white blood cell, leukopoietic growth factor, filgrastim, pegfilgrastim, and sargramostim. So it's Neupogen, Neulasta, leukeine. So it's given IV or sub-Q, produced by recombinant DNA technology, and it's identical to the human granulocyte colony stimulating factor. So it's identical to what our body makes. Acts on cells in the bone marrow to increase the production of neutrophils, white blood cells. We use it to elevate neutrophil counts if you have cancer, and also treatment of different types of chronic neutropenia. Adverse effects: bone pain and leukocytosis. So bone pain and destruction of white blood cells. White blood cells greater than 100,000. So we're always going to monitor the CBC twice a week, and we're always looking at the absolute neutrophil count to make sure that that's not rising too quickly and that it's, going back within range. Then we have thrombopoietin receptor agonists. So these drugs stimulate the production of platelets, and they're used in patients with idiopathic thrombocytopenic purpura and also patients with chronic liver failure. Okay. Ramaplostim, which is Nplate, is used for ITP, that's idiopathic thrombocytopenic purpura, when standard measures fail. So in other words, that's kind of like the last resort we can use. Causes easy bruising, prolonged bleeding. They're the symptoms of low platelets. You'll see black and blue marks, petechiae, for no reason. Reduction of platelet destruction is treated with glucocorticoids, IV immunoglobulin, and or a splenectomy, which is the removal of the source of the antibody production. So in other words, if platelet destruction is occurring, then we can treat that by giving them steroids or IVG, IV immunoglobulin, and taking out their spleen, because the spleen is where the antibodies are produced. Okay, the first one, ramaplostim, which is Nplate. What are the side effects? Joint pain, arthralgias, dizziness, insomnia, and muscle pain. But then there's some serious side effects. Bone marrow fibrosis, so which is the replacement of blood-forming cells with fibrotic tissue. So the bone marrow becomes fibrotic, and then it's not functional. Hematologic malignancy from stimulation of bone marrow cells. Always used with caution in patients with any myeloid-type cancers. Thrombotic and thromboembolic complications can occur from excess production of platelets. In other words, you can throw a clot because now you may have too many platelets. Thrombopoietin receptor agonists are always given sub-Q, and then other ones are the ones as listed: abitromobag, Eltrombopag, and Lusutrobopag. And that don't even worry about the brand names. So, in order to make red blood cells, what do you need? Bone marrow has to be intact. Your kidney has to be working properly to make erythropoietin. There's got to be iron. You need that for hemoglobin synthesis. You need B12 and folic acid to support the synthesis of the DNA. And if you're missing any of these, you will become anemic. And of course, inflammation can shorten the lifespan of the red blood cell and lead to anemia that has nothing to do with the bone marrow or the kidneys or dietary. Okay. And inflammation can occur for other reasons as well. Anemia is not a diagnosis, it's a symptom, and you got to find out why it's happening. So, most of the iron that the body has, it recycles. It's a really, really tight system. So, the principal cause of iron deficiency is increased iron demand because of pregnancy, because of blood volume expansion during infancy and early childhood, or because of chronic blood loss, usually a GI bleed, or you're having really heavy periods. It's uterine in origin. And the major consequence of iron deficiency is microcytic hypochromic anemia. You've got little pale red blood cells. And those red blood cell indices that we looked at in the beginning help to differentiate the different types of anemia. Ferrous sulfate given by mouth, PO, it's the drug of choice for iron deficiency. If patients can't tolerate it or absorb it, then they can be treated with it parenterally. Iron dextran, it's usually given IV. Major adverse effects of ferrous sulfate are GI disturbances like, pasty black stools, constipation, and they can be managed by reducing the dosage. The body can only absorb a small amount of iron in the small intestine, so it doesn't help to give too much. You have to work within the guidelines. Only 10% of the dietary iron is absorbed, so you need 10 times what you need in order to get that 10%. And if you're older folks should only take about 325 milligrams daily, according to Beer's criteria, and that prevents excessive buildup of iron in the body. As the body stores rise, the uptake of iron will go down. So in other words, once we have it stored, it's not going to be uptaking or absorbing. Now, if the body stores become depleted, uptake increases. And iron has to be properly shielded to avoid formation of toxic oxygen radicals. So iron is protected in the body. And don't give excess iron to individuals that don't need it. I mean, they have written here men. Sometimes men need it, but usually they're female patients, usually. Okay. B12 comes from animal sources, and that's a problem for vegans. Iron comes from animal sources. That's a problem for vegans. The principal cause of B12 deficiency, though, is impaired absorption. They can't orally absorb it because they don't have enough intrinsic factor. And the principal consequences of that B12 deficiency are megaloblastic, which is macrocytic anemia, and neurologic injury. Other causes of macrocytosis can be alcohol and drugs, especially phenytoin, which is an anti-seizure drug. Vitamin B12 deficiency caused by malabsorption is treated for the rest of the patient's life with cyankobalamin. And traditional treatment consists of IM, could be sub-Q, injections that are given once a month for the rest of the patient's life. B12 and iron are absorbed less in patients that have had bypass surgery, even lap band, gastric bypass or lap band. 10 to 30% of adults over 50 can't absorb iron from the diet and need some type of supplement. No acid suppressing drugs because they decrease the absorption. Large oral doses of B12 daily can be effective, but not if there's no intrinsic factor. And for initial therapy with severe vitamin B12 deficiency, we usually will give parenteral folic acid along with cyankobalamin. So they'll get the folate and the B12. When folic acid is combined with B12 to treat B12 deficiency, it's critical that the dosage of B12 is enough because the folic acid can mask any continued deficiencies of B12. It improves the hematologic picture, and then it allows the neurological consequences of B12 to progress, and they are irreversible. Principal causes of folic acid deficiency are poor diet, usually alcoholics, or malabsorption, secondary to some types of intestinal diseases. Principal consequences of folic acid deficiency are megaloblastic anemia and neural tube defects in a fetus, especially in the early stages of pregnancy. So if you're planning on becoming pregnant to prevent those neural tube defects, women should be taking in 400 to 800 micrograms of supplemental folate a day, in addition to whatever they get from food. And if you overcook your food, the folate becomes ineffective. So you're basically cooking the folate out of it. And then, of course, hematopoetic drugs. They're the drugs that increase production of red blood cells, white blood cells, and platelets. Epoetin alpha, it's given to increase red blood cell counts and decrease the need for transfusions. Specific indications include anemia associated with chronic renal failure, anemia associated with myelosuppressive cancer chemotherapy, and then last but not least, zidovudine therapy in patients that have HIV/AIDS. By increasing the hematocrit, epoetin can cause or exacerbate hypertension and also increases the risk of cardiovascular events like a heart attack, a stroke, etc. Especially if the hemoglobin level, remember this, exceeds 11 grams per deciliter, or the rate of rise in hemoglobin is more than 1 gram per deciliter in a 2-week period. Risk evaluation, and mitigation strategy, REMS, is mandated by the FDA for patients on erythropoiesis stimulating agents. Patients have to receive a medication guide. Cancer patients have additional requirements, ESA Apprise Oncology program. Hemoglobin is monitored weekly until target, which is 10 to 12 grams per deciliter, is reached. Filgrastim is used to elevate neutrophil counts, reduce the risk of possible infection. We give that to patients with chronic severe neutropenia and neutropenia associated with chemotherapy given to treat cancer. Principal adverse effects are bone pain and leukocytosis. Excuse me. Thrombopoietin receptor agonists stimulate the production of platelets in patients that have thrombocytopenia. Romaplostim, which is Nplate, is used in patients with ITP that have not responded to other treatments. Be very cautious in giving it in any patients with myeloid, hematologic cancers, or patients with hepatic or renal impairment. The end. Questions? All right, I hope you enjoyed that. Until next time, kids, I am out. Bye.